The main thing that I'm going to go through today in terms of learning objectives is one, how to read an EKG, right? Whenever you see an EKG in the field, you have to have a systematic approach to looking at key things in an EKG so you don't miss big things, especially in a chest pain patient, especially in a STEMI patient. Then we're going to go into ischemia and specifically focus on STEMIs. And after we go over kind of the basics of STEMIs, we're going to go into some of the nuances of STEMIs. So how do STEMIs look like in a wide complex QRS? How do they look like in posterior and anterior MIs? And then lastly, we'll touch on left main occlusions, which have their own presentation on EKG, which is important to note because it doesn't look like our typical STEMI. I have no disclosures to share, and we'll get started with our first case. So you arrive at a home where you find a 78-year-old man who's complaining of substernal chest pain. He states it started about 3 hours ago and it's moving down his neck and up his neck and down his left arm. So pretty typical. He's diaphoretic and pretty uncomfortable. His heart rate's low at 46 or 49 beats per minute, and his blood pressure is low at 72 or 43. And then you get the EKG as follows. So I'll let you look at this for a few seconds and then we'll kind of move on to the next thing. Alrighty. So the first question is, what do you want to do next for this patient? One, do you want to give him sublingual nitro because he's having chest pain? Do you want to give him morphine for his chest pain? Do you think they need a fluid bolus? Do you think they need epi? I mean, they're hypotensive. Or should they get amnio because their EKG is a little bit weird? So I'm going to show you the EKG again, and you could type your answer in the chat box.
C, we got A, fluid bolus, a lot of fluid bolus.
Perfect. You guys are on top of it. So C is correct, it's fluid bolus because this patient's having an inferior STEMI, and we'll talk about why that's important, why to give fluid and not to give sublingual nitro in these patients. So first I want to talk about a method about reading EKGs. So as a cardiology fellow, whenever I look at an EKG, I actually have a 10-step process that I go through my head every single time I look at an EKG, whether it's a new patient in the emergency room, whether it's a STEMI patient in the ED, or it's a new consult. And the reason I do that is so that I don't miss little things, right? If you just glance at an EKG trying to see what sticks out to you, you're gonna miss stuff. When you're in the field, there's no reason to go through all the 10 steps that I go through, but I think you should go through these 3 steps every single time you look through an EKG. You got to look at the rate, you got to determine the rhythm, and then look at the ischemia. And when you're looking at ischemia, you should look at it top to bottom, left to right, and we'll talk about what that means. So first, talking about rate. On the right-hand side here, you see kind of the normal conduction system in a heart. Are you guys able to see my mouse here? Perfect. So normally a conduction in the heart, the conduction system starts at the SA node, the sinoatrial node. It moves through the fibers here into the AV node, the atrioventricular node, and then into the bundle His, splits into the left and the right bundle, and then goes into the Purkinje fibers. That's the normal conduction system. Each part of this system has a normal intrinsic rate, meaning normally the SA node beats at 80 to 100 beats per minute. So that's kind of the normal heart rate that we have. That goes into the AV node and then down the bundle, down into the Purkinje fibers. However, let's say this SA node is knocked out, right? There's disease there, or there's just kind of fibrosis. Then most of the conduction is going to be coming from the AV node. When the AV node is the main one producing the heart rate for the body, it's going to be called a junctional rhythm, and it's going to be slower than the SA node. So this is going to be a heart rate between 40 and 60. So that's when the heart rate starts at the AV and then moves down the bundles into the His Purkinje. But let's say both the SA and the AV are knocked out, right? So you can't get the 80 to 100 beats per minute. You can't get the 40 to 60 beats per minute. The heart still has a backup rate so that you can still beat even if you have disease in those 2 areas. And then what happens there is that the impulses start in the ventricle, anywhere in the ventricle. It could be up here in the conduction system, but it could also be ectopic areas in the walls of the ventricle. When this happens, you're going to have a very, very slow rate. You're going to be in the 20s to 40s. And this is important because in patients that are coming in with an inferior MI, meaning the right coronary artery is what's affected, then that artery is the same one that supplies the SA node. It's the same one that supplies the AV node. And these patients very, very commonly have heart block and they have junctional rhythms or ventricular rhythms. So that's important from a STEMI standpoint. So when you first look at an EKG, look at the rate, because if you see a very slow rate, it could be a sign that they're having an inferior STEMI, even if you don't see the ST elevations. And then, of course, if you see tachycardia, that's something you want to note. Especially in a STEMI situation, this can make it hard to actually interpret the ST elevations if you have a very high heart rate. So after you look at the heart rate, the next thing you want to do is rhythm. Rhythm in and of itself is a very large topic that unfortunately we don't have time to go through today. But when you're looking at EKG in the field for a person with chest pain, you want to try to figure out what the underlying rhythm is. Normally, most commonly, you'll see a sinus rhythm, whether that's sinus bradycardia or sinus tachycardia. However, they can have AFib or aflutter. That can be an acute thing that happens from the STEMI, but usually they'll probably have it because they have underlying AFib or aflutter. Another thing that you could see is VT, right? Ventricular tachycardia. Whenever we see ventricular tachycardia from a cardiology standpoint, the first thing we want to rule out is ischemia, because new VT in a heart is ischemia until proven otherwise. So if you're in the field, you get an EKG and you see this normal sinus rhythm, but then all of a sudden these patients having runs of VT or non-sustained VT, that's concerning, especially if they're having chest pain, because that means that whatever ischemia they're having is affecting the conduction system, and therefore it's definitely something that we're going to have to intervene on. And then lastly, heart block, right? We just talked about back here that if you have the inferior or RCA involvement, you're going to knock out the SA node, you're going to knock out the AV node, and it's very common for those patients to have heart block. So you want to notice that stuff before you dive deep into looking for ST changes. So you do rate, you do rhythm, and then you can start looking for ischemia. So the way I read ischemia is top to bottom, left to right. What do I mean by that? So I start off with one here, lead one. So top of the EKG here, and then I go through systematically looking for ST changes. So starting with one, I don't see anything here. Going to two, maybe some kind of changes there. Going to three, okay, I see some ST elevations in three. And then I go to AVR, then move down AVL, AVF, then V1, V2, V3, V4, V5, V6. The reason I go top down, left to right is normally we're used to just kind of scanning EKG quickly and kind of seeing what stands out to us. If we do this, especially in the field, you'll miss little 1 millimeter ST elevations, because you might see these deep T-wave inversions here in the precordial leads, but you might miss a small ST elevation that might be forming in the inferior leads. So that's kind of the reason why you have to have a method whenever you look at an EKG. Always start off with rate, rhythm, axis, and then when you're looking for the ischemia, for the ST elevations, you want to go top to bottom, left to right.